Senator Storm, Senator Westerfield, here. Senator Banta, or Representative Banta, excuse me. Representative Raymond, here. Representative Stevenson, Representative Tate, here. Co-Chair Meade, Co-Chair Rocky Adams.
Here. All right, thank you. And gosh, it seems like, middle of October, there are so many things going on in everyone's districts back home. So I am very grateful that we were able to have this meeting, first of all, and second of all, for the presenters being willing to accommodate a change in time. So thank you very much for your willingness to participate today, because we do have some good stuff to talk about. I'm going to go a little bit out of order because the Kinship Care in Kentucky update, they have a time constraint. And so if we could have Norma and Shannon head on up to the table. Welcome, first of all, and then please introduce yourselves for the record, and we look forward to your testimony.
Good morning. I'm Shannon Moody with Kentucky Youth Advocates.
And I'm Norma Hatfield. I'm the president. I'm Norma Hatfield. I'm the president of the Kinship Families Coalition of Kentucky.
All right. We appreciate the committee's hearing from us today. And overall, we're going to be talking about kinship care in Kentucky and what we're seeing within the Kinship Families Coalition of Kentucky, which is part of Kentucky Youth Advocates. So thanks for having us today, and we really appreciate the opportunity to talk about what we know about kinship care in Kentucky and what we're hearing and seeing. So just as a quick refresher, when we talk about kinship care, there's oftentimes confusion about what that means. A lot of that is related to the old kinship care program in 2013, where the moratorium was placed on that. But when we're talking about kinship care overall in Kentucky, we're talking about three types. One is related to informal kinship care. This is the most frequent situation. And I'll talk a little bit about the data and who's involved in that. But informal kinship care includes those situations where parents oftentimes are arranging a situation where the child is being cared for by a relative or close family friend on their own. No Department for Community-Based Services involvement at all. Again, this is the majority, and you'll see that in the data in the next slide. Kinship care, or fictive kin care, which I think is probably what we'll be focusing on for the most part today, is those children who are placed with relatives or close family friends or fictive kin as a result of the investigation or removal due to dependency, neglect, and abuse, where there is Department for Community-Based Services involvement. And custody of the child is either maintained by the relative or by the Cabinet for Health and Family Services. And then relative foster care is another type of kinship care, and this is a more formal setting where you have the Cabinet for Health and Family Services or Department for Community-Based Services involved. A child is placed with a relative or close family friend, and it's done so formally in a foster care type setting, but with a relative. And then just really quickly, as of the most recent data that we have been able to accumulate, there are about 59,000 children living informally and formally with relatives and close family friends. A majority of these children are living with grandparents, some of them great-grandparents, but that is from the most current census data that we have been able to access. And what I will tell you is we are back up towards the top in rankings when it comes to children living with relative caregivers. We are now second highest rated in the United States. What we also know is that there are children who are living in that kinship care or fictive kin setting due to engagement with Child Protective Services. We have not been able to access current data, and I'll talk about why a little bit later. But there's estimates of around 15,000 children being raised by relatives in kind of that more formal setting. And then we also have as of October, 946 kids in relative foster care.
So there's been a lot of progress made over the years, and just to kind of highlight some of these, in 2014 we had the kinship caregiver authorization affidavit, which allowed relatives to have a form so they could make medical and educational decisions. We had a kinship hotline established and hosted by DCBS. Child care assistance was a huge one for a lot of kinship families, and they didn't have to have a copay, and their income considerations were not a big factor to get this benefit. Regulations changed for relative placement benefit support so that they could receive that electronically instead of through snail mail and all of the long bureaucracy channels. HB1 included language so that we had more kinship support, legal access to de facto custodians, and HB2 in 2019 with a service array and a collection of reporting data around kinship care. 2019 to 2021, we had DCBS Kentucky Faces. This is when Family First really kicked into gear, and there were more options as far as kinship foster, fictive kin in those areas. And then, of course, University of Kentucky Kinship Resource Center in 2021. Now, I didn't say this when I introduced myself earlier. I am president of the Kinship Families Coalition of Kentucky, and the reason that I became an advocate for so many families across the state is because in 2014, my 2 granddaughters were put into the system, and it did not work the way it needed to. They went straight to foster care, no phone calls, no nothing. And we were in the system for 18 months until my husband and I got permanent sole custody. Living and breathing the system and talking to so many other caregivers, and I'm going to tell you tens of thousands since 2014, and hearing their stories and their needs and their struggles, we've come a long, long way. And I can tell you that when I first started walking these halls and trying to meet with the legislators back then, the majority of them didn't know what kinship care was. Or they thought they knew what it was, and that's not what it was at all. And now I can tell you that pretty much you can walk the halls and every legislator knows. I mean, talk about HB1, talk about HB2, look at the things that are happening. We've had bipartisan support wholeheartedly across the board as far as kinship supports. And there are so many families out there that really appreciate it. We are in Kentucky doing more for kids, but there's still so much more to do.
And this committee has been essential to making that progress, especially after House Bill 1 established this committee, but then in subsequent years related to a look at fictive kin, as well as some of those increase in the service array. So we really appreciate the work that has happened. So what Norma had alluded to related to some of the changes that we still need to see, I want to give just a quick overview of something that the Kinship Families Coalition has done recently. In 2021, we hosted a Kinship Summit, and that was kind of the 5-year mark since the first Kinship Summit happened, to bring awareness to the number of relatives who are raising children in the state of Kentucky. We did a series of focus groups across the state as well with relative caregivers who are engaged in support groups in some way, or who had been known to the Kinship Families Coalition as a result of outreach. We still get calls on a pretty regular basis about the old kinship care program and that $300 a month. Even though it has not been around for almost 10 years, there are still questions about it. So we hosted that the 5 focus groups and interviews, and what we still heard was there was an improvement in access to services. People are starting to recognize that services are available, especially financial services. Across the board, what we heard was that there is a real need for improved communication from the Department for Community-Based Services, as well as other agencies that support the relative caregivers and their children in some capacity. There is an urgent need for behavioral health supports. You're also going to hear that from Michelle Sanborn. For our relative caregivers who don't necessarily always know how to navigate the system of behavioral health supports, it's really essential because you have kids who have experienced trauma, who healing from that trauma or potentially just experience the adverse effects of that and are really in need of behavioral health supports. Another identified need within these conversations is around legal supports. A lot of our relative and fictive kin caregivers don't know how to navigate the legal system, and oftentimes they are not Child Protective Services involved, so they don't have somebody there to help them navigate that either. And they are often looking for ways to, one, make sure that they can make, those medical and education decisions, but then also if they're looking to pursue a more permanent situation as far as custody goes, they need to know how to navigate that as well. Again, ongoing financial supports is always a need. You have a lot of relative caregivers who are grandparents who are on a fixed income, taking in kids who are growing up and eating more and needing new shoes and all of that. And then continued access to training. We heard from our relative caregivers that they need to know what to anticipate when raising kids now as opposed to 20 or 30 years ago. It looks very different with technology, with the requirements for schools, with a lot of other things that they need to navigate. They need training around that, as well as training on how to mitigate the impacts of the trauma that the children experience. There's also a lot of discussion around how to navigate the parent, grandparent, or parent relative scenario as well, because that is just a tricky relationship to navigate. And then we've also been getting calls, like I had mentioned, around just better understanding the system, navigating the system. We have folks reach out to the Kinship Coalition that think we're the Department for Community-Based Services sometimes, asking for status updates on their benefits and support. So we are often directing them to, thankfully, the Kentucky FACES program, which has been a great benefit. Do you want me to start? So we came here with some recommendations to consider as you all continue to dig in further around kinship care, relative care supports. Norma's going to talk about a couple of these, but I did want to talk about a really clear opportunity that we have been not ignoring necessarily as a state, but haven't shown a whole lot of priority around, which is the Guardianship Assistance Program, which has been available from the federal government since 2008. There are 40 states, 10 tribes, and the District of Columbia, as well as Puerto Rico and the Virgin Islands, who take advantage of the Guardianship Assistance Program. It's a Title IV-E reimbursable program. Obviously, there are some state dollars that would need to be committed as well, but it allows for relative caregivers who are taking kids into a foster care situation, and it allows for them to access funds after the 6 months are up, so that when they move into permanent custody, they can still get some of those financial supports that are often available to foster parents as well. So just looking for some equity related to foster care and kinship care.
So I wanted to highlight three main topics that come from this. And the first one is the Kentucky Transitional Assistance Program, or Ktap. So that is a program that is very much appreciated. But what's happening with a lot of in this case, grandparents that I'm talking to, is that, just kind of put it in this perspective. You had no notice. All of a sudden, you're taking in 5 kids. You are single. You're on disability. Your income, you did not plan any of that. That's pretty much what we know happens with a lot of kinship families that are out there, is no planning, but you do what you have to do to take care of family. So they go and they apply for Ktap. And what's happening is that there is a child support component that kind of hangs them up. They have to acknowledge that if the biological parents don't pay child support, that they could lose their Ktap. Well, to me, that doesn't make sense. It is seriously impacting a lot of families, because you're low income to get Ktap in the first place, so you don't have a lot of resources. You already have less resources because you're taking on all these kids up front, and you may, there's all these unplanned things that you need to do, and you can't focus on taking care of the kids because you're worrying month to month, are the biological parents going to make their child support payments or not? And am I going to have this income next month? Foster families don't have to worry about this. They get to do what they're supposed to do, which is focus on the kids and navigate the system the way that it needs to be done. They don't have any other burdens of other people that they can't control, confusing this and complicating things. And I think that's something that we need to look at is we're talking about low-income families that qualify for this, that are under stress and duress and doing the best that they can, and they're having to take their focus off and potentially losing these services. The income levels, I believe, with where Ktap is, I think it's 4 kids to get to $300. Now think about that. I've had grandparents specifically tell me this. The money that they would make in a year for 4 kids is probably less than a retainer fee for an attorney to go chase down the biological parents and to take this on and to get that reinstated. And they give up. And that, to me, defeats the whole purpose of what this program is about. And it hurts the kids in the long run. The second one, Shannon talked about the guardianship assistance program. So think about this. You've got families out there that are electing the foster kinship option, and that is huge for them. They are taking care of the kids while they're in the system. But as soon as custody is reached, the door slams shut. You might could go to Ktap, which is way low compared to what it was before, but what they're receiving today, and there's nothing else. And there are states out there that are doing this kind of program. And I think what we need to do is think about long term. If you get a 4-year-old and you're in the system for 2 years, and so that child is 6 years old, what are you going to do to raise that child from age 6 to 18? There's not a lot of support there. And I just feel like while we're grateful for the fact that we have the foster option out there, it drops. It just drops like a hot potato, and there's nothing else. And it's like, sorry, the case is closed. You figure it out from there. And long term, we're draining other resources. That grandmother that's out there that is in her 60s living on Social Security, she had that support for the foster pay option, but then what is she supposed to do for the next 12 years? And so she's going to end up like so many kinship families that are out there, losing her car, losing her home, being bankrupt, and eventually she's also going to be pulling from the system. And I think if we start looking at some of these potential opportunities, long-term families are just going to be a lot better. And then the last one falls around communication. I have helped several grandparents with this, and I still hear that it is a problem, though it is getting better. So a grandmother, she got a phone call from DCBS. And in this particular case, her grandson had also been in a home where there was meth. And the social worker comes to her, and she's distressed because she's first hearing about this. And she gets a form, and it says, what she's basically told is, you can take custody of your grandchild, or the state will take custody of the grandchild. That's all she heard. The form had three, I think it's 3 options on there. So immediately she said, I don't want the state to take my grandchild. So she checked the box that I'll take that temporary custody. And then she found out a couple of days later, after she got the child settled, she dealt with the medical pieces that felt with taking care of that child because of the exposure to meth. And then she finds out, I could have checked the box to take the foster care option as a kinship person, and I still could have kept the child. But I didn't understand that because I was in distress in the moment, a form being shoved at me, and all I heard was, you can take custody or we will. And I think that, while that is getting better, that is an area that I think could use some improvement. Because, like I said, I am still hearing from a lot of grandparents out there that are having this situation. And once you waive it, you waive it.
Thanks, Norma. The last 2 are related to a pathway for respite care. Again, just looking at the access that foster parents have related to supports, making sure that we also have respite care supports for our relative and fictive kin caregivers who are doing the same job, playing the same role. Oftentimes are more stressed, older, and have more challenges. They are in need of respite care. And then finally, there in House Bill 2 of 2019, there was a option to create a report for kinship placements upon request of, I believe it was this committee. We saw one in 2020. And what I would love to see and recommend is we need to continue to know and understand the data so that we can adequately support the relative caregivers in Kentucky, and we don't have access to that right now. So I don't know if it's feasible for maybe every 3 to 5 years to consider requesting that report to get adequate data so that we can make decisions on it. But it's there, it's in statute, just asking for the report on a more regular and consistent basis might benefit all of us.
And I just want to add, there was a senator that I talked to a couple of years ago before this report was a requirement. And when I was asking for some more services and assistance, what they said was basically, well, if you don't have how much it's going to cost, which means if you don't have the numbers, I can't help you. And so we really do need those numbers.
We appreciate the time. If there are any questions, we're happy to answer them.
Thank you very much. And, it was interesting because you got to it, but that was one of the things I wanted to follow up on is the report from House Bill 2. That was from 2019. And so you're telling me we still don't have that data.
There was a report that came out in 2020.
Okay.
Not released to the public necessarily, but provided to the appropriate committees that were identified in the statute. But having some more consistent access to those numbers for you all and for folks who are interested in seeing those numbers and also advocating for what needs to happen is really important. So just a recommendation that, I don't know I think every year is probably too much and potentially a burden for DCBS, but having those numbers on a regular basis would be beneficial.
You think a yearly report is too burdensome?
Well, I think
I'm assuming that the intention of the legislation, my understanding is that it's, again, a yearly report that will help us shape policy once we have data.
Yeah, I think that the statute said a release in 2020 and then upon request.
Okay. Thank you. And a question, you talked about the connection between Ktap and child support. Is that a statutory fix, or is that something that we have that has to happen on the federal level?
It's at the federal level.
Yeah, it's that child support component is on the federal level. I think the hope is to not put that burden directly onto relative caregivers to pursue it. It would be to have potentially another entity pursue that child support. Because not only does it cause a burden to access attorneys, but also just the relationship between the birth parent and the caregiver gets strained pretty significantly as well.
Okay. Thank you. This is very enlightening. I love the update. And thank you for what you all do in this space, because it's super important and it's the most economical way, but we have to do a better job of supporting the families that are participating in this. Does anybody have any questions before we move on to the next one? Okay, thank you.
Thank you.
And as Terry Brooks and Shannon, you're staying.
Yep.
We're going to go through the presentation on the Kids Count data book. Let me go ahead and take up the approval of the minutes from the September 14th, 2022 meeting. Do I have a motion to approve the minutes? All right, I have a motion and a second. All those in favor signify by saying aye. Any opposed? All right, the minutes are approved. All right, welcome. We have the famous Terry Brooks at the table. So please introduce yourself for the record and proceed.
Good morning. I'm Terry Brooks with Kentucky Youth Advocates. And last year she was, Madam Chair, she was Shannon at University of Kentucky has now told me that she's now Dr. Moody. So just so we know that. Thanks so much for the time. I also really appreciate you hearing the kinship report. Y'all have heard me say Judy and I have 8 grandkids. 5 were at our house on Sunday, all Representative Raymond's constituents, and that was for fun, and I was exhausted by the end of the afternoon, so that notion of respite care can't be emphasized enough. We really appreciate you guys taking time to think about our Kids Count report. Some of you, the chairperson for sure, has heard about Kids Count enough that she could probably do the presentation. But I do think it's important that we make sure we're all on the same page. So before we get into the data and implications, I want to take just a moment and remind you guys what Kids Count is. Over 30 years ago, when UPS began becoming a philanthropic force, they started asking questions about the state of kids across America. And what they heard were plenty of opinions, anecdotes, and stories. What they did not have was data. If you know anything about UPS, you know that they are not interested in data. They are obsessed by data. They really want to know how long that package car driver takes to get from his or her vehicle to your front porch, back to the vehicle, and on the road. So UPS's corporate folks designated one of their philanthropic arms, the Anna E. Casey Foundation, to essentially invent a report card on America's kids. The next thing they did was approached a group in each state, and that varies. KYA is unique in that we are the only advocacy group that is a Kids Count sponsor. In Indiana, it's IU. In Tennessee, it's actually the governor's office. So we're a group that sort of merges data and policy in a unique way. On an annual basis, Casey puts out in June, they put out the national report. That really says where Kentucky ranks in 4 domains: health, economic well-being, education, and community and family. They do 4 indicators on each of those. So you have a 16-item report card, and we know not only which items we're improving in or declining in, but we also know how we compare to other states. When I look at that national report, I don't know about you, first of all, I want to see the trajectory. How is Kentucky doing compared to Kentucky? And secondly, I'm really interested in Tennessee and Indiana and Ohio, more so than Oregon and Connecticut. We then take a step that actually I think we're the only group in the country that does, and that is that we disaggregate all of that data by county. I'm hoping each of you have county profiles for the counties that you represent. So you should be able to look at your counties or county or counties and see how they compare to Kentucky and how they compare to the nation. So just want to make sure we're all on the same page as to what that is. In terms of a quick overview of where we stand this year nationally, in terms of improvements and declines, you can see that those are the 16 indicators. You can see that overall we have a lot of indicators where we're doing better than we did previously, and we have other indicators where we see a decline. The thing that I would caution you about, and you already know this, is in every one of those indicators there's actually good news and bad news. I'll take that first one because I've always had a hypothesis that unless and until we address childhood poverty, nothing else matters. We know that economic well-being so impacts health outcomes, education achievement. So you look at that, and we need to celebrate. There is no question that we need to celebrate that we're on a 4 or 5 year trajectory of a decline in childhood poverty. And yet, when there are 250,000 kids in Kentucky today who live in poverty, we can't celebrate where we are. The other area that each of these represent, and again, I'm going to use poverty as just one example, is if the General Assembly is serious about disparities, digging into those data points provide remarkable information. As an example, the typical county in Kentucky has an 18% childhood poverty rate. What fascinates me is that the 6th poorest counties in Kentucky, 6 southeast Appalachian counties, and the 6 lowest income census tracts in Louisville. So the most urban and the most rural communities in our state, they have identical poverty rates at 40%. So you know where I go on that, which is that policy solutions, for instance, when it comes to childhood poverty, are just as applicable in urban areas and rural areas. The solutions can find a common ground. So again, we would be happy, because I think the chairperson has asked us to limit this to 4 hours. We can go into each data point. But I just want to highlight that any of these that you're interested in as a committee or individually, we are happy to talk to you about it. We do an analysis of all 16 data points with policy implications. And we also look really hard at what other states are doing to address each of these areas. So what? I mean, you all get a voluminous amount of data and a voluminous number of reports. And I am very aware that if all we do is talk to you about numbers, they sit on your shelves. They sit on my shelf at least. And so we understand that it's really important to think about the so what. I would suggest to you that there's two particular applications that I would respectfully request you consider. One is the potential for local action. One of the things that we do a lot is county-based kids count conversations. We, in fact, recently just finished an 8-county tour. We started in Paducah and we wound up in Manchester. In each of those places, we had legislative leadership, county judges, superintendents, police chiefs, preachers, policemen, community advocates, and we dug into that county's kids count data. Really, what are the priorities? What could we do? What are actionable items? And I'm probably going to get in trouble with my KYA colleagues for saying it, but if we always say to any lawmaker, if you're interested in a kids count conversation in your district, as long as you provide the coffee, we'll be there. And we would love to be able to engage you in this. I want to just highlight one example, and that example is in Barron County. The folks in Barron County really put together a robust county-level kids count conversation. And I just want to give you this as an illustration, not necessarily what you would do. The first thing that we at KYA did was we were able to generate foundation support for the community at around $25,000. So we did not want folks to come together and just talk about it. We wanted to say that if you come up with a plan, we'll help you implement it. A local business leader actually raised a local match. So we walked into that summit with $50,000 on the table of discretionary money for Barron County. As they dug into the data, they came together rather quickly, and as a county wanted to focus on family reunification. They ran the numbers. They literally implemented a 5-year plan where they knew that in order to improve by this percentage, they had to reunify 52 kids in the county a year to reach their goal. The first expenditure of that $50,000 was seemingly every faith-based community in the county gave out T-shirts with the number 52 on them on a Sunday. The last time we had a Children's Advocacy Day in person in Frankfort, Barron County brought 3 busloads of community leaders, all wearing 52, and guess what? They actually are headed toward that goal. So I lift that up simply to say that our goal with this data on one level is to give local communities specific, measurable, and attainable goals. And we love the idea that we see cross-sector folks coming together at a county level. So certainly one implication is around local action. And you know where we're going for the other one, which is policy. Knowing who is on this committee, I kind of wanted to raise your thinking a little bit. and that is that more and more research, both from Brookings and Michigan State, have started looking at state legislative policies. And they've developed what they call a typology of state-level policies. When they look at those, their contention is that and this is not for y'all, and it's not necessarily in Kentucky, nationally, that a lot of legislation gets passed that supports trends that actually are dying, that we're supporting efforts that no longer should be supported. They also see a disproportionate number of policies that simply continue current practice. What this particular piece of work does is they look at innovation and return on investment. And their contention is that if you want policies to create a return on investments, both economically and for constituents, we have to look at boundary spanning issues. And so Dr. Moody and I want to talk to you just for a second about some potential boundary spanning activities. As some of you know, certainly Senator Rocky Adams, what we tend to do before we announce specific proposals is we meet with both House and Senate leadership, go over here's what we think the blueprint is going to be, and we're getting ready to do that. So these are not on the docket yet, but I think they're coming. When we think about boundary spanning, first of all, and you all get this, you all as committee members certainly understand that child welfare is affected by everything. I mean, you can't talk about child welfare and not talk about economics and health and education and community violence. So almost any policy that the General Assembly looks at, in my opinion, is a child welfare policy. We also know that some child welfare policies come from data and some come from experiences. Right now, we're working on one of the other things we do that some of you know is occasionally one of your colleagues will ask us to handle a constituent issue. We're looking right now at 3 parallel cases for 3 members of the General Assembly. And there's also a Louisville media outlet that's looking at a 4th case, and they're all identical. And that is that young people who have beyond severe health issues are in kinship situations or just regular parental care situations. And for some reason, what those parents face is to get the medical help they need, the only achievable way to do that is to give up custody. Now, if you as a General Assembly value family stability, I'm assuming no one in this room wants a parent or a grandma to be faced with the fact to get my child the help I need, my only alternative is to give up custody. So we're just beginning to explore that. Some of you may know far more about that, certainly probably some staff folks do, than we do. I'm telling you, that's a boundary issue that I'd love for you to look at. How do we get parents and grandmas and grandpas the help they need without giving up custody of their children? Here's another example, and I want to give you just one more, and then I've asked Shannon to give you a couple. Representative Bana may know this has been kind of on our radar for a long time, and it continues to be. In the world of schools in Kentucky, those comprehensive schools in your district, that high school up the road, the elementary school around the corner, they are called A1 schools. There's also a group of education entities called A5 programs. In most districts, I don't know how to say this politely, but they're generally the places where kids who have been suspended go, okay? So they are the kids who, for whatever reason, aren't perceived as being able to make it in A1 programs. But there's another category of programming that certainly fits this committee's oversight, and that's A6 programming. That's education programming for children in state care, juvenile justice, as well as DCBS. I am convinced that is an arena that demands some kind of program review and evaluation. I need to say that everyone does not agree with our assessment, and that's why you're hearing me hope that folks would do a review rather than you just trusting our recommendations. I think if you dig into that, what you'll see is, for instance, lack of academic achievement. Kids in foster care graduate at barely more than half the rate of the rest of the state. What does that mean for economic viability? Because my sense is that these young people are not moving to Silicon Valley. They're going to stay in your community, and we'd better find a way to make sure they can read and write and do math. Secondly, we are convinced that there is an issue of financial inequity. What I perceive, and I know you're going to hear from Ms. Sanborn in a minute, and she's also has been working with us. What we perceive is that there are certain entities, frankly, probably in Senator Rocky Adams, Representative Raymond, and Senator Berg's area, big residential facilities in those communities produce really good A6 programming. But when you ask them, they tell you that it's because they put in millions of their own money. So that Home of the Innocents or Brooklawn or Bellwood, they are providing services, but it's because they're doing their own version of a bake sale. It's not because they're getting the money they need. In residential facilities in more rural areas, those kids are suffering. We hear on a consistent basis that those kids, the most vulnerable in the state, are getting leftovers from, A1 schools, or they are inadequately staffed or equipped. So we have questions as to the fiscal equity that's at play. The final area is that I believe, knowing where you guys are, a review of the locus of governance. In other words, who is responsible for this? There is a third-party entity that is responsible. DCBS is responsible. DJJ is responsible. KDE is responsible. I mean, I don't know about your experience, but mine is when everyone is responsible, no one is responsible. So you know the challenge, because if there is a group of young people who don't have school board members or PTA moms, it's kids who are in state custody. And so I would invite and ask that you all as a group, or however normal committee structures work within the General Assembly, an area that is ripe for a program review. And then sort of Representative Banna, in my head, it's can we do CARA for A6 programs? Can we do an education reform package for A6 programs? That's a real boundary spanning ROI item. So Shannon, you want to bring up a couple others that we'd like you to at least start thinking about as the session approaches?
Thanks, Terry. So a couple of others that are just on our brains, and as Terry had talked about, conversations are definitely still needed with the General Assembly related to these. But Kentucky Youth Advocates has the privilege of facilitating a group of judges, the Department for Community-Based Services, and Administrative Office of the Courts. And we do that because there's a need for cross-collaboration, and having an external facilitator is helpful for that. And the reason I'm telling you this is because in the last several meetings that we have had, all of those entities are in agreement around the same issue, in that there are issues with timeliness to permanency for youth in care. So whether it's timeliness to adoption, timeliness to reunification, there are major issues in that space. We also know that oftentimes state social workers are put in situations in court where they're having to respond to questions that frankly they shouldn't be responding to or need to have the answer for because they're not attorneys. But oftentimes, because of the way that the cabinet is represented, that is the situation that they're put in. So, and we've worked with the Office of Legal Services, the judges, AOC, and DCBS around a recommendation related to ensuring that there are the processes by ensuring improved court processes by transferring the presentation of the case from the county attorney's office to the Office of Legal Services, along with the allocated resources, so that there are attorneys who understand and know from the Office of Legal Services how to present a case for these dependency, neglect, and abuse cases adequately and in a way that gets us to faster permanency and better outcomes for kids and families. I know it's really kind of in the weeds, but that's a recommendation that was created by judges, the AOC, DCBS, and folks who have been thinking about this for quite a while. Another recommendation or something to consider for this group is the development of an external ombudsman's office. As you all may be aware, the current ombudsman's office is sitting within the Cabinet for Health and Family Services under the Office of the Secretary. Back in 2018, when House Bill 1 was in development, this is actually a recommendation that we made because what we are understanding and what we continue to hear is that services that foster parents, kinship caregivers, birth parents, and sometimes youth in care need are not often getting addressed in a timely manner, either because of the strain that's put on the current DCBS workforce or other issues within the system. They call the ombudsman because that's kind of their last resort, and then things just die sometimes. And what we know is that if we had an external facing ombudsman or externally situated ombudsman, there'd be a whole lot more transparency and opportunity to drive the system based on those trends that they're seeing, and folks would be more aware of what those trends are based on the calls that they're receiving. And then finally, and this is one that you all have seen on the blueprint before, related to cross-agency reporting. Right now, if abuse is suspected within a particular agency, that report is being made from that agency, and it could be made to that agency. So, for example, if a police officer is an alleged perpetrator of abuse, somebody can make the report to the police, and then it can live there. That report isn't required to be made to the Cabinet for Health and Family Services or the county attorney's office, which, as you all can imagine, can create some real problems with it not being communicated up the chain or across agencies to then be dealt with. We saw this in Louisville within the Explorers program. We would like to see it's a minor statutory change that would need to be made in order to make that possible.
Now, we can keep going, but what we wanted to do was just highlight some of those boundary issues that we anticipate bringing you and try to get you involved in thinking about those early on. We obviously would welcome your questions. We appreciate this committee, both collectively, individually, and certainly the chairperson's persistent support of what we do when it comes to kids and families and child welfare. So that concludes it, Madam Chair.
Yes, thank you very much for your all's presentation. Your Kids Count book is like the Bible for people, members of this committee. I mean, we really comb through those numbers and those recommendations. I'm really glad that you brought up the A6 schools. I've never heard of that, but as you mentioned, Jefferson County is having a really intense conversation about what we do with juveniles within our community that are disruptive. And, there's two schools of thought: incarcerate them, or, how do we have some sort of mitigating environment for them to respond to and come out of. And I like that. Anything that we can do to have some more ideas about how to handle that.
Being very candid, two things. One is Senator Westerfield and I were just talking. I think there's a committee meeting actually tomorrow that actually is going to begin looking at the Louisville Detention Center. Yeah. But I would suggest to you that it's really a state system. We're working closely with Lori Givens and her team at AOC. I think what they would say is that whole notion, Senator Westerfield facilitated a conversation a couple months ago on that. The whole conversation around trauma-informed care for young people who either have made a mistake, we're not denying that kids make mistakes, or those young people who, for instance, have been neglected and abused. As an old, broken down former public school administrator, when I look at the education, just the academic provisions that are going on for those schools, for those kids, it should embarrass us all. Madam Chair, without beating a dead horse here, part of the issue is it belongs to too many people in too many places. Yeah. Secondly, I think that there is a lack of transparency in governance, that we can't have that program governed by parties of self-interest. We need a group that looks at the results for kids. So we're happy. We have notions in the Louisville situation. We actually were very emboldened when Louisville closed that. To his credit, Governor Bevin and then Commissioner Butler had actually put together a group of Louisville nonprofits. And some 20 nonprofits had come together to craft a strategy around a community-based diversion and detention program. That did not move forward. We actually facilitated that. And again, being very candid, we hope that the mayoral election in Louisville produces an opportunity for us to resurrect that idea so that we get out of this lock them up, throw the away. You're not hearing us say don't hold them accountable, but let's not throw away the key. On a statewide basis, and I'm not, but if I were a representative from a more rural area, I would be deeply concerned about the lack of financial resources that kids in both DJJ and DCBS facilities have. Those young people should not get the condemned library books from the A1 school. They should not, this is a double negative on purpose, they should not be taught by non-certified teachers, because they actually need higher quality, more highly personalized, more differentiated instruction than the typical kid does. And so for the kids who need the most, we're tending to give them the least. And so we would, depending on your all's direction, we would be happy to put together some thinking on A6 and move that ahead.
Thank you. That's really important. And I have one more question for you. On your very first page, the 2022 Kentucky State Data Profile, one of the things that we did better on is children without health insurance. Like, don't we have the ability to have every child covered?
Yes, and we're getting close. We're really a national model that began several years ago and has continued. I think what we've run into is that final group that we don't have. We're gonna, and I think folks in the cabinet would agree, we're gonna have to get more and more innovative to get that final couple percent. But the overall effort has been really good. There is always that gap between 100% and 98%. But that is a real win on a national, that it's a national model of how Kentucky's gone from a low percentage to a really high percentage of young people covered.
Okay, awesome. Well, unless the committee has any more questions, thank you very much for your presentation. It was fabulous. And I will be following up with you on that.
Okay.
Okay, last but not least, do you think we saved the best for last? We have Michelle Sanborn. She is going to present from the Children's Alliance. Please introduce yourself for the record and proceed.
Good morning. I'm Michelle Sanborn, president of the Children's Alliance, and thank you for having me today. I'm going to move it closer here. Speak louder. Here we go. So thank you for having me come this morning, Chairwoman Rocky Adams. I appreciate it, and committee. I could talk all day, and I can get kind of a little passionate and long-winded. So I'm going to stick to my 15 minutes. So I'm going to try to follow my script here. That is my 15 or 20. I think it was 15 or 20 minutes. So anyway, as Dr. Moody and Dr. Brooks communicated, there are some positive things going on in Kentucky. And actually, I just spent a week with some colleagues from across the nation, my counterparts in other states. And actually, I left feeling pretty good about Kentucky. So I was like, let's do a pat on the back and talk about some of the good things we're doing. But us, as well as other states, have a lot of room for improvement in child welfare. So today we're going to talk a little bit about the positive that's going on, but we're also going to talk about some pain points and kind of build on some of the things that Dr. Brooks and Dr. Mooney communicated. As you can see, this is just point-in-time data provided by the Cabinet for Health and Family Services here that are out-of-home care numbers, that top pink numbers, are starting to go down. We went up over the years, but we're working to move to reduce the number of children in out-of-home care. Foster care, both PCC foster care families, DCBS foster care families, are holding steady. So we're continuing to recruit foster parents. We need more. So if anybody's out there watching, anybody here, we need foster parents. We need more kinship care parents, and we need more foster parents. So I will say that. And then lastly, our reduced number in residential. This line doesn't really show it, and we're going to talk a little about that because I think that's one of the things we really need to celebrate. But I'll go on and we'll hit that reduction in residential. I think, so when you see those point in time and you can see what we're doing in Kentucky as a trend, I also like to point out where are we in compared to kind of the national average. When I hear my colleagues talk and hear what's going on in their states, I say, how are we doing? So I pulled out Kentucky in 2006 data and Kentucky in 2020, and that's the most latest or current data that I can get through the federal AFGAR data. And this is actually federal fiscal year data. The last PowerPoint was really point in time because that's what I have for Kentucky. But you can really see that we're doing a great job reducing the number of kids in residential. We do a great job at foster care. Obviously, you can see we need to do a better job of increasing our kinship care. And you heard Ms. Hatfield share some of the movement that we've been doing. We've been making strides, and we're going to continue. You can see the improvement, but that's obviously the area you can see where we need to continue. But I do want to take an opportunity to say congratulations to the state of Kentucky. Congratulations to providers, to administration, to the General Assembly for working to reduce the number of kids in residential. I know that in May of 2005, that was when I was at the Cabinet, we had 20% of our children in out-of-home care were in residential services. Today, we're at 7%. And we're going to talk a little bit about the silver lining to that, but also it is definitely still a cloud potentially in that reduction. So we need to be really careful. We're being innovative, and we're moving to the front end, and we're providing different services, and we're ensuring only those that need treatment are in treatment. But we also need to make sure that we're supporting those kids that are there. That 7%. So just wanted to share a little bit about where our kids going. And again, in comparison to the United States, we're doing fairly well with that. Okay, emancipation we could probably get a little bit better at, work to getting those families. The Family First Act, a huge federal act that was implemented in 2018. It really had two parts of the bill. One was to create what we call qualified residential treatment providers, or QRTPs, and I'll just probably refer to them as residential. I've used that term. That's the old term. That's going to be my term. Most of our agencies across the state that do residential services are QRTPs today in the state of Kentucky. And it also allowed for drawdown for prevention services. The mandate for all states to implement was October 2021. Kentucky was an early implementer. We implemented our prevention services in October 19 and have already implemented our QRTPs across the state. But as of today, so all that happened and several years ago, 30 other states have approved prevention plans. So we're way ahead of the curve. I think we were one of maybe the first 5 states to really get an approved prevention plan. So again, doing well by working to move to the front end and working to make sure that those children, one of the big components of the QRTP legislation was making sure only those children that need treatment are in treatment facilities, and those that don't need that level of service should be served in families. So I wanted to show you the full continuum of care as far as in child welfare and involvement. And I would say, I wish I would have done like a link and put like a chain, because part of me says if any piece of this continuum is weak or fails, then the rest of it falls, right? So this really should be really a circle or a chain or a link. But you can see it takes all of these different levels to serve the type of children that we work with. The child welfare involvement is all across the continuum, but I put 2 arrows to really show I would say two key points in the system that I think are really important for us to acknowledge. And one is a time of investigation. So we get a referral, someone says maybe there's been abuse and neglect, and we go in there. And then we have this family preservation piece here, something that you all have invested in, and we've actually doubled our services in the last few years so that we can prevent that removal. And so I think removal is really key. And the reason is it's key because it's once we put a child into out-of-home care in our foster care system, it's costing the state about $58,000 per child today. And then kids are staying in that system for an average of 25 months. So 2 years, right? Many of our kids go back home in months, maybe even weeks in some cases, but a few months. So the majority of our kids are moving quickly through the system. But on average, you can see if you look at the whole continuum, which means some kids are staying in our system for years. And again, it's costing our agencies or our state, and it costs our children from being away from their families. So it's really important that we really focus on, I should actually go back, where that removal is, on that family preservation, putting an investment in those services to keep those children from coming into that kind of more restrictive care, I call the back end, and this is the front end. And then also making sure we look at our community-based behavioral health services. So there's 2 areas that I would call our prevention. I would say secondary and tertiary prevention, and we can talk primary. I've been talking a lot to our colleagues at Prevent Child Abuse Kentucky about even moving further to the front end, right, which is where I would like to see our boundaries go, right? We should be moving to that front end, but really focusing on those 2 areas. And one of the things we have focused on is that family preservation area. And I stole this slide from, I asked DCBS if I could use this slide. You all saw this slide in July. Krista Bell presented this slide, but I love this slide because it shows that our investments in that family preservation prevention services is actually showing a decrease in the cost of our out-of-home care, right? You can see that it's working. So thank you for that investment, and know that we're going to continue to improve this and work on this, but that's an important and key place. So I think, again, overall, we're doing well. And later, you can see some of my colleagues are really struggling. So I want to make sure that we're not falling into those concerns that some of other states have gotten into. So I really want to share really 2 concerns that are, I think, burning or pain points in our continuum of care. And I think there's some concerns, some of which Dr. Brooks brought up today about qualified residential treatment programs and resources there. And our residential agencies, and then also our community-based behavioral health services, which is prior to DCBS interventions. So the intensity of the behaviors of our kids in our residential agencies has gone up. And you're going, why is that? Well, now we're only serving those kids that need treatment, which means it's not just a group of kids like in a school where you have some that are a little more intense and some that are a little over, right? You've culled out, and now we're very intense. I had a program tell me just yesterday that they used to be able to serve 12 kids in a cottage, and now 7 or 8 is all they can do. They said it's just the acuity and need and treatment need of the kids that they're serving today are so severe that they cannot continue to serve that many in one setting, right? They have to make sure that they're keeping those kids away. And some of the behaviors that these kids are experiencing are cutting themselves, a lot of self-harmers, very aggressive toward themselves, towards others, towards the staff. I'm hearing a lot of they're inserting objects inside their bodies. Places that you would not even think about inserting things that are very dangerous because they're crying out for help and they need treatment. These are the types of kids that we're serving. And their behaviors are to the point where our psych hospitals are not serving them. We have 2 agencies right now that have 2 children each that have taken their children to the psych hospital for admission, and the hospitals are saying they're too severe. So I've reached out to the Hospital Association because if the hospitals can't take them, then what, right? We're like, what? But we have to take them back in our residential facilities. They can't not go anywhere. So we need to make sure we have the staff and the people to treat those kids. And I know the Hospital Association is working with DCBS and working in partnership to try to come up with solutions and recommendations for proposals to treat these kids. But in the meantime, they're at our residential facilities and we need staff. And if you haven't heard, there's a workforce crisis all across the nation. So again, my colleagues that I was commiserating with are all trying to figure out what to do in regards to the workforce. But we did a survey of our members prior to the pandemic, and the residential direct care staff was only being paid on average $11 an hour. We've gotten a rate increase, thank you to you all, so we appreciate that. And today it's about $14 or $15 an hour. And so $14 or $15 an hour to take care of very severe youth, not a lot, and I'll show you a little bit more on that in the next slide. But you can look at our reported turnover rates. It's gone up to 80%. If your staff not only are not getting paid and then they're turning over, what kind of quality, what kind of treatment, what kind of training, what kind of experience are we seeing with these direct care staff? And many of our residential agencies have really had to stop taking referrals. They can't, had to close cottages. And again, we can applaud that we're not serving, but at some point, we're gonna reach this threshold where will these children go, right? So we have to be able to serve those that need treatment. We're doing assessments now that only those that need treatment are in these facilities. So if they need it, and then we don't have the staff and we're closing these facilities, where are they gonna go?
Can I ask you a quick question on that?
Sure.
I know I'm interrupting you.
No, fine.
If we don't have the ability to serve those children, do they go out of state?
They have. In the past, we've had a lot of kids, and now they're starting this trickle out because we brought them all back, and we've been working. We had concerted efforts to do this, but now they are starting to those numbers. And I don't have those numbers on me. I wish I did. We can talk to DCBS about getting those. But we are starting
it costs
to
more
It
to
does.
send them out of state than to try to figure out our workforce issues right here at home.
Well, and then they're away from their families. There's
Yeah.
no family work. There's no reunification, right? They're far away.
Okay.
So we have made concerted efforts to bring them back, but when we get to this point where we're hitting, right, where we're hitting this base, Where else are they going to go? And other states are calling us. I actually had a call from a judge just, I don't know, probably 2 months ago. And he was trying to get names of my agencies so that he could send his kids across the lines to our facilities. And I told him, look, easy, because I'm trying to protect what I have to make sure that we're caring for our kids. But it is definitely an issue. So last week I just got on and said, what's the going rate if I were to get a job to be a hostess or to work at Costco? And this is Louisville last week. And you can see it's more than what these kids, what these young men and women are making as direct care staff, working with critically just traumatized and treatment children. So it's really important that we focus on ensuring that these residential agencies have enough resources to hire the right staff to keep these kids safe, and that we are serving those that need the treatment. So the other area that I want to talk about is behavioral health services. So this is the front end. This is before DCBS involvement. And as you can see, we're in a national mental health youth crisis. So there's two things going on: increased need, and then again the workforce crisis is gonna hit us. So we've got two things converging. I have agencies right now in the state that their boards are talking, like literally right now, about closing their behavioral health services. I have an agency who's already closed their behavioral health services. They cannot continue to work and provide the therapeutic services needed in our communities with our families due to the reimbursement rate. And I'll show you a little bit more about that. But on a national level, we're seeing increased depression, increased anxiety, increased ER visits, increased suicide attempts. So the crisis is ramping up. At the same time, we're losing staff. Last year, December, so beginning of this year, we did a survey of our behavioral health providers as part of the Children's Alliance, and they were on average 11 weeks long on a waiting list. So 11 weeks, so that's 3 or 4 months. I can say that as a parent of a child who struggled with some mental health issues, that when we tried to work through a lot of things at home, right, before what I would say calling for help. It's, oh, we can work on this. We know the source of this anxiety. Let's work. I've talked to teachers, talked to people at church, right? We kind of surrounded, like, try to help the issue. But it reached a point where I needed to ask for help. And I was able to, because I had the luxury of calling a private therapist and paying privately to see somebody that week. If they would have told me, oh yeah, we'll see her, and we'll see you in 11 weeks, I would have said, well, I mean, the crisis will be over then, or she might not be here then, right? That's where we are. And so 11 weeks in my mind is not access. And if we're required to provide Medicaid access, medical access to these services, but then we're putting them on an 11-week waiting list, that's really not access. And you can see where the behavioral health members' turnover rate is again growing. That's been really a steady job, but their therapists are leaving in droves. And you can see, here's the Kentucky Medicaid rate. In 2014, which was really the implementation of where they opened up BHSOs and MSGs, which is our multi-specialty groups. So it's those that are in the community beyond our community mental health centers. This was the established rate for an hour of therapy. It's just one service. These providers provide many other types of services, but a common service is individual therapy with our families. It was $75.30 back in 2014. And in 2022, it's today, this is our current rate, which is $78 an hour. And if you just Google the U.S. CPI calculator, you can see that same buying power is actually $95. It's over a 25% increase from 75 to 95%, and that's what we need. There are many of our states around us, they're getting paid over $100 an hour for an hour of therapy. CMHCs on average get paid $100 an hour. $95.34 is not, actually, that's almost too low to ask because they need more than 25%. That's where they are. They are losing hand over fist, and boards are saying we can't keep up with this. Along with the workforce kind of shortage, they're struggling with getting the therapy, they can't keep up with resources, we've increased our administrative burden on these agencies. So what I mean by that is we have 6 MCOs, and they're asking for audits of these folks, which they should, right? We should be making sure that they're being paid for and doing what they say they're being paid for and asking to be billed. But I have a member who has not really grown over the years, but in fiscal year 18, 19, 20, 21, on average, they had about 597 audits the whole year. In fiscal year 22, they had 2,100 audits. And as of July and September, 2 months, they've had 601 audits. And agencies are saying that they complete 4 different types of audits with 6 different MCOs. And when it started, the MCOs were asking them for a list of records like this, and they said, you have a week to get those to us. And of course, providers called me, and I was just like, wait a minute. We don't mind getting you these records, but you have to give us time because, oh, guess what? We're treating children. We're therapy services. We're in their homes. We're traveling. We're behind because we're losing therapists, right? So the MCOs did work with us to extend the time frame to provide those records, but the records just keep being asked for them to provide these audits. Oftentimes, they don't even hear back from the audits, which is very frustrating. I think they do all this work, and it's just like, so where are we? So also, they've reported that because of billing and these audits and things, they've had to increase their administrative staff. One agency said they went from 7 to 11 staff just in their billing program. This is a large program, right? Another agency, a small one, said that, oh yeah, they've had to quadruple their services, their administrative staff. So we're growing our administrative staff, but we're decreasing our treatment because we can't get therapists. One of my members who provides a lot of services in many of your areas, they used to have 35 therapists and a kind of a growing program. But over the years, they've lost therapists, and they can't recruit ones. They only have 10 left. And so while they're continuing, and they're one of the agencies where their board's asking, do we need to keep doing this? And they want to because they're committed to serving these youth in their homes. They're the ones out in the communities keeping these kids from coming into out-of-home care or in hospitals, but they just can't keep up with the demand. So workforce administration. So there's kind of 2 different things really hitting community-based providers too. And so I'll ask you for kind of 2 solutions. One is we really need to increase the behavioral health rates. And it needs to be more than 25%. I know that seems like dramatic, but it's like we've got, something's got to give if we want to continue to either sustain, but we really need to grow that program if we want to keep kids from going into out-of-home care. This is just an example. 25% would cost the state $16.5 million to raise those rates, the overall behavioral health and BHSO rates. And it would draw down another $38.6 million. So for me, I just think adding a 70% federal match is really a win-win because this is money that's going to be going for salaries. And I think economic development, it's for salaries, for money that goes back to consumables and taxing. But it's really about making sure that we have those therapists on the front end or we're just going to continue to be paying higher rates and for more kids on the back end. Mandated services. These are those that are available in the community. So I've talked a lot, and you know me, I like data. I probably could go work for UPS, what Dr. Brooks mentioned. I'm very practical. I talk about efficiencies. I want to save the taxpayers money. So I'll show you numbers all day long. But in the end, it's about the children and families we serve. And so I've included in the PowerPoint 3 success stories, because this is the most important outcome. This is why we do what we do. And these are 3 success stories from behavioral health providers that have served these high-end kids successfully to keep them from out-of-home care or hospitals. This first story about a child who really had some severe behavioral issues because he had a brain injury. And the therapist actually ended up going and walking him to and from school to keep him safe and to know where he was going to run to keep him, right? They worked with him to reduce his extreme behaviors, and he's doing well, and he actually comes and checks on them. Success story 2 is about a child that in the school, this provider was working in the school to manage these behaviors and reduce his restraints really at school. And also they worked with the family to ensure that they had what they needed. And today the mother has a job and the child is doing well in school and no restraints. This, we've really de-escalated for this child. And lastly, again, a child physically aggressive, had assault charges, should have really been in kind of a GJJ type system, but we got him a diagnosis of autism, and he started treatment, and they've been working with them, and he hasn't gone in the hospital. He hasn't had any more incidences with the police and the school. So when I asked for some success stories from my agencies, they're like, I had things coming left and right. I mean, I could put success stories down all day long. And so I just think it's important that we focus on this is the positive outcomes, but it's, again, the less expensive thing to do. So what can you do? Support resources for residential agencies, increase our behavioral health rates so that we can sustain those services. We're getting ready to lose, a handful I could name right now. Obviously, I can't name them. If we continue to erode that system, they're just going to end up in this system, right? And so we really have to protect that link and support that link, or the rest crumbles. And then supporting legislation to reduce the number of MCOs to 3. I'm for managed care. I believe in it, and am working well. We have great partnerships with the MCO. Six is too many. The administrative burden on our agencies right now, it's just too much. Having 6 different ways to do things is crazy. I think I do have an email that I'll quickly read and then I'll wrap up. I just got this from a behavioral health member. It says it's hard to keep up with the rates so low, especially since we're traveling to a good number of our patients, whether that be in the home or school. And Medicaid doesn't pay for travel. And these are people that are in the home working with these children and families together. And it says, for example, at one point this week, I had to drive out to a school, see a guidance counselor who was there, who was involved in a crisis, spent an hour with the child, drove back, wrote my notes, and so I spent a little more than 2 hours plus gas, and I was able to bill for 1. It's no wonder these young therapists want to hang a shingle and sit on their couch and do telehealth. It says, with that said, my biggest complaint right now, it continues to be the never-ending audits. I got one from one MCO on Thursday, and I got that finished, and on Monday, got another one. I just don't have the staff to keep up. So it's important that we try to reduce the administrative burden. And if we don't do this, we're going to look like my colleagues. These are links to news articles all across the nation. Many of these states have reduced residential. Many of these states have reduced their detention center, which we want to do. But if we don't support the alternative services, we're going to end up on the front page of the paper like them.
Thank you, Michelle. I really appreciate your presentation. You went through a lot of stuff, and it's good, good information. You know, one of the things I was thinking, I agree with you on the MCO audits, but part of the reason they do it is because they can. And so I'm thinking maybe an idea that we explore is maybe co-chair Mead and I send a letter to all of the MCOs and ask them to justify why they are burdening. I mean, are they finding rampant fraud? I doubt they are, because I know how these organizations operate, and they're all good citizens. So maybe, you know, we explore something like that. Say, you know, this is really putting a burden on our system, and so justify to us why this is so necessary. So anyways, that's just an idea that maybe we can follow up on. But we do have a question from Senator Berg.
Thank you for a wonderful presentation. This is really not, I have two questions, if that's okay, Madam Chairwoman. But my first question really isn't for you. I think it's more of a question for us, which is, can we not simply require the MCOs to consolidate their data, you know, to come together and find out what information do we really need to make sure that we have the information we need to provide adequate services and to make sure that the quality of services provided is being adequate. But instead of each of us individually requiring this data from everybody, consolidate the data so that as a state, we know what we're looking at, we know what we're asking, we know what we're monitoring and auditing, and less of a responsibility on the individual providers to provide data all over the place that's not even being used, apparently. So that's just a thought. You know, can we require them to consolidate their data? My second question, if I may proceed, is possibly a question for you. I have two constituents in my district now, both of whom have gotten their master's degree in mental health care services at a University of Denver. And apparently their accreditation program is not allowed here in the state of Kentucky. So both of these young women, one state is still in Denver working, the other one is taking a position in Indiana, because her degree, even though it is from a school that has recognized national credentials, we don't recognize them here in this state. Are you aware of anything that can be done to resolve that?
So it's working with the state boards on reciprocity, and we have been working with the various boards on trying to get reciprocity. So it would kind of depend on what their degree is in and which board, to communicate with that board to try to make sure that they get what they need in order to be licensed in Kentucky.
So who initiates those conversations?
So they can reach out directly to the board.
Done.
Or they can contact me. I've
Okay.
had lots of conversations with the board over that. But again, we've really been trying to push them to have reciprocity with all the states for this very reason, so that individuals don't have to do that.
Okay, thank you.
Okay, any other questions? Seeing none, thank you. I really appreciate it. And before we adjourn, I just want to make an announcement that the next Child Welfare Oversight and Advisory Committee is Wednesday, November 9th at 1 p.m. And I promise to not to have that change. I know. All right, so if there's no objection, we are adjourned.
That's what they tell me. Such a